Hello, everyone. Thank you so much for joining us today. We are excited to bring to you some really exciting and awesome content, advancing community health through CHWs, so research, recommendations, and actions. And just before we get started, I have a few housekeeping items. Wanted to let everyone know that we are recording today, and the slides along with the recording will be sent to all the registrants after our session. As the presenters are sharing today, I encourage you to submit your questions through the Q&A feature. And at the very end, we'll be sure to leave some time to answer those questions. So with that, I'm going to hand it over to Heidi Arthur to get us started.
Thank you so much, Tiffany. Hello, everybody. I'm Heidi Arthur. I'm a principal at Health Management Associates, and I do a good bit of work with community-based organizations, with community health workers, with peer support specialists, and all the networks and hubs that support and enable their participation in the broader delivery system. So thrilled to be bringing you this really exciting information today. Our agenda is going to include just discussion of the important role that CHWs play as trusted sources of information within their communities. Then we're going to explore how information flows both to and from community health workers up through the system of supports that provide care to people in the community. And then we're going to share some key insights and some recommendations that have been gathered from community health workers in Illinois, specifically in the Cook County region of Illinois around Chicago. And then we're going to have a panel discussion. We're going to hear from community health workers and advocates and employers from the folks who are presenting about the work that they're doing and sort of some of the findings, get some real insights from them. And then we're going to have a wrap up with questions and answers from you. So with that, I'm going to turn it to Wandy Hernandez to introduce herself and talk about CHWs.
All right, thank you so much, Heidi. Hello, everyone. My name is Wandy Hernandez, and I am the co-executive director of the Illinois Community Health Workers Association, so-called ILCHWA. I work to unite and support CHWs and partners statewide. With the background in human service management and over 30 years of experience, I've dedicated my career to advocating for marginalized communities and elevating CHWs in Illinois. I'm honored to join our partners at HMA, Sinai Urban Health Institute, and Michael Reese Health Trust in celebrating Community Health Worker Awareness Week, an acknowledgement established by Congress in 2023. Next slide, please. Oh, that's it. Okay. That is what I was referring to in terms of the CHW celebration. And so in alignment with the Happy CHW Awareness, with the National Association of Community Health Workers, of which I am one of the founders and served as the inaugural president, we collaborate with other statewide CHW entities to celebrate the National CHW Awareness Week. On the first day, as you guys can see here, ILCHWA began the celebration by encouraging CHWs to take a photo and to tag us on our social media platforms. Now we are on our third day, and the question is, what do you want to tell people about your work? This question is to relay the work that CHWs do and the impact that they make within the communities that they serve. These 5 days are extended to educate people who are not familiar with the CHW scope of work and to inspire and empower the people who are doing the work, which are CHWs. Next slide, please. Letitia Boughton Price and I lead the Illinois Community Health Workers Association, advocating for CHWs and employers. Our members are preparing for CHW services to be included in the Illinois Medicaid, which will strengthen the CHW workforce statewide. ILCHWA has over 700 members, and about 80% CHWs and the rest are employers and allies. Our members are statewide, with most in Chicago and in the suburbs. Next slide. CHWs help people get healthy, stay healthy, and avoid costly repeated ER and hospital admissions. During the COVID pandemic, an array of grants began to expand the CHW workforce throughout Illinois, delivery systems supporting training programs and establishing initiatives designed to integrate CHWs into the most heavily impacted communities. Now, CHWs bridge care for people facing barriers like chronic illnesses, mental health needs, homelessness, and other challenges beyond traditional healthcare. Next slide. And so what is the impact of a CHW? CHWs connect with their communities because they are locally recruited and trained. They provide health education, help people access resources, and address needs like housing, food, and transportation. CHWs improve health outcomes and lower costs, but they need supportive systems in order to succeed. Community health workers are the bridge between healthcare systems and the communities that need them the most. By supporting and investing in CHWs, we're not only improve health outcomes, we empower individuals, strengthen communities, and build an equitable future for all. And together, with ILTWA and our partners, we can continue to empower community health workers, strengthen our communities once again, and create a healthier, more equitable Illinois for everyone to come. So thank you so much. And I would like to pass it on to Heidi. Thank you.
Thank you so much, Wandy, and thank you to all the CHW associations. Many states have one, some states don't they still don't have one. And so really we value greatly our philanthropic partners. And so we're also delighted to be welcoming Gina Masada-Barrett to talk a little bit about the support provided by Michael Reese Health Trust in supporting an analysis of what it takes to provide that support that Wandy flagged CHWs really need in order to be those vital, trusted messengers within the care delivery system. So Gina, I'm going to turn it over to you to talk about the community health information ecosystem. It's a mouthful, and it's so important. Thank you for joining us.
Thanks so much, Heidi. As Heidi mentioned, my name is Gina Masada-Barrett. I am the Program Director for Health Workforce at the Michael Reese Health Trust, which is a Chicago-based health foundation that has long supported CHWs. As Wandy just highlighted, we know CHWs are essential, trusted communicators, navigators, and sources of community insight. But they are doing this work in an increasingly complex environment. Funding for CHWs is under pressure. Policies and programs are shifting, and health and service information is changing rapidly. At the same time, people are receiving confusing and conflicting information all the time, which makes it harder for them to know what information to trust. And too often, CHWs are expected to bridge these gaps individually. So, as Wandy highlighted when she talked about having systems support CHWs in succeeding, the question is not just how we strengthen CHWs, but it is also how we strengthen the systems around them so they can do their work more effectively. That's where this assessment, vetted by key partner organizations and CHWs and led by HMA, comes in. And Michael Reese and the Community Memorial Foundation were very happy to support this vital work. Next slide, please. So this assessment focused on the CHW information system. The people, the organizations, the relationships and processes that help information move between systems, CHWs, and communities. That includes health and public health information, benefits and resources, service updates, and community questions and feedback. Importantly, this was not about asking CHWs to take on more. It was about understanding the systems and connections around them. What's working? Where are there gaps? What could better support CHWs in getting timely, accurate, and trusted information to communities and bringing community insight back to the systems? So this assessment is one piece of the broader CHW ecosystem and our larger goal of strengthening the systems that support CHWs. So thanks, and I will turn it back to Heidi.
Thank you, Gina. Thank you for making this possible, this exciting report. So let's talk about what it takes to enable CHWs to be trusted messengers, because this is what we learned from CHWs who have in fact been trusted messengers within the community for some time now in Chicago and are preparing to continue that work under the Medicaid program with a new Medicaid benefit in Chicago. And so this is a little bit of a Chicago, Cook County use case that can really be more broadly understood within the national landscape for CHWs and how they practice. So thank you. The Cook County, Illinois CHW Information Ecosystem Assessment is actually fully documented in a report that's publicly available, and we're going to make that available to you in the chat. But this assessment, it included, to start, just a real landscape assessment of the CHW communication practices and evidence-informed models that have been documented to date. So we looked to the literature, we looked to reports, and then we also looked at the environment, sort of what are the sort of systems and entities that are doing CHW work within the Cook County region to kind of just understand the landscape. Then we had focused informant interviews with advisors and experts from the local community, really focusing on, the leaders in the CHW employment space, CHWs themselves in learning collaboratives, and we're delighted to have learning collaborative leadership represented today for our panel with Kim J joining us. And we did focus groups. We did focus groups with leaders, supervisors, CHWs, and we talked to organizational leaders from training, advocacy, and community hub entities. So our assessment was fairly broad and deep within this community, and our analysis really did focus on what are the current information pathways that CHWs today are using and that employers and systems are relying upon. What are the trusted sources of information in the environment, and how is information being validated now? What is the feedback loop that exists or doesn't exist from the community back up through the system to make sure that community insights are really being fed back into the system for ongoing improvements? And we learned about, kind of where do the risks come in terms of misinformation, and what kind of workforce vulnerabilities are there in terms of the CHWs and the really often overwhelming work that they do. What kind of infrastructure opportunities could the system at all of its various levels take on board as the Medicaid benefit is being developed and rolled out in order to really scale and effectively integrate CHWs into the system? Next slide. So we learned that CHWs have no one information source. It's really scattershot. They get information from their employers, the organization where they work. They get information. It comes in from internal trainings, from staff meetings, from local gatherings within the community, within their networks, from the CBOs that they liaise with, the community-based organizations that they rely on to provide services to the people that they're serving. They also rely on them for information about updates and news and information, particularly directly related to services that are available or often not available in the community. So they're kind of like having to navigate, kind of what's readily accessible and what's not. And they really do rely on, as Wandy highlighted, their association at the state level. There are listservs and networks, peer networks and formal CHW collaboratives, as well their own relationships within their community, within their personal network. It's very informal as well as formal. And it's really, we learned that the Cook County ecosystem is robust and asset rich, but it's fragmented. There's no one sort of formalized process or methodology for how really targeted information is getting to CHWs in a standardized, uniform way that they can really kind of make actionable. Next slide. So right now in Cook County and in probably many places across the country, CHWs themselves are both that trusted resource for information and the infrastructure that's necessary for communicating that information, because they don't have a real structured process for streamlined verification and adaptation that is necessary for them to kind of transmit that information to those they're serving. So right now they themselves are receiving information from a variety of places. They're having to personally and individually customize and adapt it, tailoring the message so that it can be received by the communities that they're liaising with. They're often having to respond to things like misinformation, fears from the community, kind of requests for information that maybe they don't have readily accessible. They have to kind of figure out how to get it. They're having to do their own confirmation to confirm that information is up to date, that it's reliable. And they're having to call organizations directly one by one as they work with people to ensure that resources that they think are available are still available. So there might be resource guides or directories, but they often have to make that call just to say, is this appropriate for this person? Is it available still? Is there a wait list? And they're also having to personally be that messenger to identify gaps, needs, and community concerns, and sort of lift that back up to their employers and within their organizations kind of individually, a little bit ad hoc. So what we heard from some of the CHWs we talked with is, they're doing this as part of their daily lives. One CHW shared, I carry materials in my pocketbook because when I'm on the bus or in the train, I might be asked by a community member for information. And so I'm always delivering messaging and working essentially. So they are always doing that, and they're always customizing it for those they see. And there's really not a support system to necessarily guide them in that in all places in Cook County. Next slide. So the 5 main gaps that we heard in that information flow really did have to do with fragmentation, not having shared mechanism to validate or synthesize. And so information that they might be receiving could be out of date. It could be, inaccurate. It may not be reliable. There's no place to aggregate and synthesize. Access can be uneven. So some employers have mechanisms for regular updates and information sharing. Some broader delivery systems have listservs. Some states, like Illinois, does have an association to share regular information, but access is really uneven across the system. And a lot of that resource information about services for people being served is just out of date. And the eligibility restrictions or the availability of those services changes sometimes day to day. And so it can be very difficult. That can take up a lot of bandwidth for a CHW, just kind of knowing what's out there for their population and whether it's actually accessible. And then the feedback loop, that sort of like community intelligence, like what they're learning about barriers to care or about issues that might impact uptake of vital health information, that may not be reliably and consistently moving upstream to prompt action within the system. We heard some great examples of when that does work, what that looks like. Regular gatherings where there's kind of an open call, CHWs participating on the board to kind of really, represent the community. But for the most part, what we were hearing is that it's catch as catch can in terms of whether that's available within a given organization or community network or delivery system. And a big takeaway was around workforce strain, really hearing that CHWs are just getting deluged with very difficult and overwhelming issues affecting their communities. They're taking that in, and it's often really a tremendous emotional burden, as well as just a day in, day out. Like I said, they're always sort of working. So the community stress that is affecting the communities that they literally target, because that's the role of the CHW, is also stress that they themselves feel because of the work that they do and because they literally represent the communities that they serve. So frequently they themselves are also affected by the very same issues. And so just some examples that we heard, CHWs saying that people tell us to take a mental health break, but we're going home, we're caring for our families, our communities. So that doesn't really assist us, right? Like we really don't get a break. Or if they're facing some of the same issues as though they serve, the concern, now I'm going to be seen as fragile, just like my community. So that burden was a big piece that we heard from CHWs. And it's sort of gap and a potential frisson in terms of being that vital feedback loop. Next slide. So we also learned that information alone does not guarantee that there's access to that information. So having a referral to service doesn't work if the service isn't available. And this was a really constant refrain. Need the reliable information about services in the community, and it needs to be actionable for the population being served. And really a lot of information we heard from CHWs had to do with language access and services being just overwhelmed by just the volume of people in need, and people not feeling safe necessarily always sharing information about services that they need. Maybe there's stigma, maybe there are barriers, and so sometimes is CHWs having to kind of dig for what is required, or there are access barriers related to transportation or other issues just in terms of actually utilizing available benefits or assistance, such as people who have access and need for food, but nowhere to store it if they're in a shelter. So some of those things are barriers to actually having the service get to the person. So one of the CHWs said, information flow is one thing, but if there are no services, what do we do? What do we do about that? And so feeling a lot of sense of helplessness was a part of the workforce strain that CHWs reported. Next slide. And then the recommendations. So what came of this analysis was we did the landscape scan of appropriate methodologies and things that work for information feedback loops from CHWs to CHWs, kind of that effective dialogue between community and the systems meant to serve the community. And we found that there were recommendations that kind of cross the delivery system. So top-down policy makers, agencies, funders, philanthropy can really support this workforce, can really make certain that there's adequate compensation and effective supports to really enable them to show up and be able to be in this role with accurate information, but also with effective, salaries that make the work a livable wage, as well as policies that protect the role that they play, and practices that support communication. Public health, healthcare, and cross-sector leaders, they can align messaging. They can sort of develop processes and approaches to provide some of that pre-verification and aggregation of information and really strengthen the multilingual referral system. So establishing some best practices, supporting training. We really heard the report is chock full of really great ideas for how they can put into place some of these supports. And CHW networks and care hubs, community care hubs, and partners in networks, they can coordinate peer learning, provide message review for CHWs, and adapt and support the feedback loop. They can really kind of be that engine, if you will, within the system to facilitate that ongoing dialogue between community and within the system. And then within organizations, employers and leaders can really support huddles for CHWs, bring them together, assist with verification, really establish and maintain directories of available community resources, and help to elevate that CHW feedback. Again, the report is full of great ideas for how to do that, and we'll be hearing from our panelists about some great ideas too. On the front line, CHWs can validate, adapt, share, and escalate their concerns And they can do that all best when they have really strong supervision, when they have peer support from their colleagues, their network, and when they recognize the vital value of the role that they play and know that they can rely and lean back on the systems that are there to provide that infrastructure and facilitate their role. Next slide. So every gap that we identified has an infrastructure solution. And so we talked about some of this, validating and synthesizing with one function across systems. It doesn't mean that it's all the same information, but that there's kind of like a streamlined way that it is done in a particular region. Providing multi-channel dissemination, so keeping it open and flexible, but providing access to those resources and making sure that all CHWs have that access, and then providing that verification and availability of information, particularly around eligibility and service capacity, and providing materials that are culturally grounded, linguistically available, not relying on CHWs to translate and adapt everything that is most important, but really that providing some of that structure to facilitate that for CHWs, and then providing that kind of debrief and followed through within organizations to help CHWs kind of have the support and escalate concerns in a routinized way that is maintained. And certainly the supervision, the peer support, and paid learning. We really hear that CHWs require additional training, and some guidance in the report speaks to motivational interviewing and reflective listening as really being important core training for CHWs, in particularly related to their information role, as well as just real clear leadership around this important activity that CHWs are kind of passively expected to play, but need to be formally activated and empowered to play. Next slide. So in Cook County specifically, we really had a lot of great information about a lot of assets were there, a lot of resources, but really the value is in having a shared backbone entity, like a community care hub model that can really provide that kind of trusted message validation, maintain that multilingual, culturally grounded adaptation function, and really provide the visibility into what services are available and support the workforce. So we recognize that the state of Illinois is actually doing this. There are going to be community hubs that are being resourced. There's an RFP out right now for social care hubs. And we're excited that that complementary capability is going to be validated and is going to be supported within Illinois for timely dissemination and resource verification for real structured CHW feedback loops with clear governance and accountability. And now I will turn it over to Letitia Reyes-Nash to introduce our panel. And I believe first we're going to hear an introduction from Kim J. at
Thank
SUHI.
you. Yeah, thank you so much. And you can pull the slide down so we can see our beautiful panelists. Wonderful. Well, it's so great to have such an illustrious group of experts on the phone today. And Kim J, I know you're jumping in here, and I would love, I think back to a report probably about 15, 20 years ago that SUHI put together around, enablers for community health workers. And so you all have been working, studying, iterating, and really building an effective model to integrate community health workers into workflows and into the infrastructure of a hospital and into other organizations. I'd love to hear if you can introduce yourself, and then please share a little bit about what are those enabling factors? Like what makes because a community health worker's experience successful, and having that two-way street communication with the employer. Please tell me what you've learned in all the work you all have been done at SUHI.
Thank you, Letitia. As you stated, I have been a part of SUHI, who has been honing the work of community health workers for over 25 years. My role is as a lead facilitator for our crowd training program, which is our Center for CHW Research Outcomes and Workforce Development, and also Sinai Urban Health Institute, which is the research arm of Sinai Chicago. I've been doing this work for over 14 years, and I've been just very grateful to be a part of the evolution. And when it comes down to the mechanisms that ensure community health workers are integrated into systems and to teams, is the idea of receiving them as a part of the team, not this outlier that, oh, by the way, here's this community health worker who can do this ad hoc work or this miscellaneous work, but an integrated part of the team that is recognized, that is acknowledged, and has a space within that organization. Because sometimes I've had experiences where CHWs have been employed and have been given this space in an organization, but don't have a physical place to sit or land because they are not recognized as the employee of an organization that is going to be doing some very hard work within organizations that can change health outcomes. So when it comes down to what needs to be done, it's acknowledgement from the top down, so that the reception of this community health worker is not a misstep, but is something that's absolutely intentional.
Thank you. Yeah, absolutely. And I think the one thing, I mean, I think I've been lucky enough to have worked with you all, during the pandemic and other roles. And I think, the pandemic was a real lesson, I think, for many of us around the value of community health workers and understanding the closeness to the community information. And so while we've been talking about, communication, pathways and infrastructure, the piece I want to lift up a little more is that piece around the two-way street. What we have so much to learn as institutions and organizations from community health workers, because they are on the ground and know the needs and know emerging issues, challenges, and problems before these institutions even understand that something is going on in a community. And I would love to invite Wandy or Gina, because I know Gina, you and I were sitting next to each other during the pandemic. What are some of those lessons learned that we should be pulling forward around that value of that two-way street communication, not just disseminating best practices, but also learning from our community health workers on how we need to be adaptive on our communication tactics, on our outreach and engagement, on our even on how we are working to bring folks to these systems. So Wandy, I don't know if you want to jump in, and then Gina.
Yeah, Leticia. I would actually say that the first thing that comes to mind is, respect, right? Respect and equity. As you mentioned, that's when CHWs became known, but we've always been here. It's just that during that time, that's when we were highlighted. And why? Because a lot of our own people, our Black and Brown people, were actually dying, in numbers, in greater numbers than anyone else, right? And so that was a huge issue. And a lot of our CHWs also lost their employment, because they weren't considered essential workers. Even though they weren't considered essential, they still continued to do the work. They still went out there to communities. They still actually, assisted the people that really didn't understand what was going on, because they didn't even know what was going on. We all were in the dark at one point, right? Misinformation that was coming out through television, through media. There was a lot of stuff going on. And so here we are trying to scrambling to see how we can actually even assist our own. But I have to say, CHWs are always have been resilient in the work that they do, right? Resiliency is key. And it's unfortunate, but we've always had to actually be resilient in the work, right? Not only personally, but in our work in terms of how we do things. And so they were the ones that continued to do it. And some CHWs actually lost their lives, but we don't hear that. We don't hear about CHWs that really didn't know what was going on and actually lost their lives during, that crucial time in the pandemic, right? And I just feel like that is something that we need to lift, right? That CHWs have always been here. We've always been essential. And we continue to actually demonstrate that through the type of work that we do, how we impact community. That is our secret sauce. We know the ins and outs of community, and we're able to link them to resources and educate them, culturally appropriate. That's what we do and how we do things, right? And so it's really important for CHWs to be viewed as professionals, as experts, because they are experts within community. Just like, other care teams are experts in terms of what they do, wouldn't it be nice to have a CHW included in that care team, right? To be able to actually unite, to really hear in terms of really what's going on within the community. Because those, the CHWs, as I've always mentioned, have been the pulse within community, right? So they're the ones that really know what's going on, regardless of the fact of what people hear, right? When they actually, when patients actually, have conversations with their care providers, but the CHWs do know. And so it's just really important to actually raise that up. And so I'm just going to leave it there because I can continue on.
Yeah, thank you. No, Wendy, no, I
Pass it over to
appreciate
Gina.
that. Yeah, yeah. And if Gina and Kim J, if you have anything to add, I mean, I think really this idea of, of again leveraging this expertise, this knowledge, but also providing infrastructure and systems that are going to enable and make it easier. And I saw a question that came through from Judy Monroe around the utilization of AI potentially for ways to be able to help make these communication tools helpful. And I really appreciate that recommendation because I actually at a meeting right now where I'm learning about a lot of interesting tools that are out there that that will allow for that communication loop to be strengthened. And so I appreciate you highlighting that opportunity, Judy. So thank you. Does anybody else want to comment on kind of this infrastructure piece? Go ahead, Gina.
Yeah. No, first of all, thanks, Wandy. I love your passion, and commitment to CHWs. I think an important piece to highlight is the infrastructure that you're talking about, Letitia, in that the networks and collaboratives of CHWs where they can learn and support one another is vital. It is like mandatory. It's not nice to have. So prior to joining the Michael Reese Health Trust, I was at the Cook County Department of Public Health, and they had built a suburban Cook County learning collaborative, which is still in existence today and trying to figure out how it will be sustained. And Kim J from the Sinai Urban Health Institute has been instrumental in that. And I think, again, not only the support, but the system of, we used to call it tri-directional communication from the local health department to the organizations and CHWs, to community and back. And I think that's really important because there's a lot of learning that can happen both ways. And to your point, being responsive and adaptive based on what is learned.
And just
Go
to
ahead,
add
Kim.
on,
Yeah, and Kim J, would love to hear more about that, about the collaborative and what are some of the values you're hearing that CHWs are saying about having that platform?
So first, I'll just say in that question you asked before about the two-way
Yes.
information street is just trust community health workers to be the trusted messengers. We hired them because of the skills that they possess. And we want to recognize that if I hired you, I trust you to do the work that you say you're going to do. So I want to respect what you hear, see, and know. And when we were in our learning collaborative stages that began in the throes of COVID, they were the saving grace for many community health workers and organizations that employed them. They, as Wandy stated earlier, they were at a space of just like not knowing what to do or how to move forward. But they were the essential workers who had to be outside in community to do the work. So what did we do in those learning collaboratives? We supported that energy that was there. What is it that you're having challenges with? What do you need to help move forward in this work? Because we didn't get a pause. We had to continue through the avenue of being contact tracers to then being being vaccine ambassadors, and more things. But it was important that they had that sense of community there, where they were able to share their concerns, share their vulnerability, but then as a collaborative, lean on each other with what were the best resources that they saw, what was happening, how do you get there, what do you do? And as a result, they had an internal network of community health workers that were able to support them even in their different disciplines and areas of expertise because they were the boots on the ground seeing that. But the reality is, when they saw what they saw and saw the changes happening, they were able to relate that to their organizations. And then in turn, their organizations were able to pivot because they had one idea about what was needed, but the community health workers saw the whole opposite of what needed to be done. So trusting them as your employee to be that trusted messenger, to share those nuances and changes and bring them back to the organization is what we should really lean into and know that community health workers are resilient but fragile. And they need a space to restore that's intentional so they can continue to do the work that's essential. I'll pause.
Absolutely. No, no, that's excellent, Kim J. I mean, I think that there's been having these different platforms for information sharing, for learning. We've been working with our steering committee, with the various organizations that are engaged with community health worker work, and just keeping organizations and community health workers aware of the different policy work that's happening in the environment, I think is a really critical piece. And I know you all are also delivering training and substantive value to those individuals. And so as we're thinking about the workforce, CHWs as a workforce, you've just identified, some of the needs around, trust, respect, integration. I heard, treating them like building that expertise that they have. One of the other things I've heard, we've talked about before is, and I've witnessed this in working in other states, that oftentimes some of the resources that we may be offering the community may be things that our community health workers need. Tell me a little bit about how you have seen organizations be responsive or not responsive to that reality.
Absolutely, Letitia. As I would say, as being one of the lead facilitator in these learning collaboratives and creating content for them and just sitting with them, what I did learn and was able to just to create that safe space around was understanding that we hired people from the community to do this work, right? And we were able to even see real time that there was a community health worker actually working in housing stabilization, but they were homeless living in their car with their 2-year-old child. But they didn't feel confident enough to tell their organization that they were in this situation because they didn't want to be perceived as weak or not capable. But when this conversation came up in the Learning Collaborative, every community health worker on that screen was able to say, I have resource, I can help you, I can do that. And they were able to rally together and get this community health worker housing when they thought that sharing that vulnerability would be to their demise. But they were very grateful for having a space that they felt comfortable and confident enough to share these things because, with the very definition of a community health worker, they are a person who has a close relationship, understand the community, maybe having some of the same situations and health issues. And knowing that, you have to realize that the person that you hired could very well be going through the same thing that they are championing in community. But we have to understand with that knowledge, am I a safe space for my employee to come and talk to me about that? Do I look like the enemy when I should be the ally for my employee themselves. And so when employees are feeling confident or feel safe at the organization that they work for, you will then in turn get to those situations that could be a barrier. They're social determinants, so they can be effective in their role because they're still turning the role and the work out, but sometimes they are left to fend for themselves in the very need that they're supplying for the organization. But with the Learning Collaborative, we were able to be that support and still continue to be that support in these areas because a lot of community health workers don't feel confident or safe enough to talk about these vulnerabilities. But in the Learning Collaboratives, we can get this information and help them lift it up to their organizations so they are more empowered and that what the organization may be missing, they can now be a part of the solution.
Thank you. I saw a question in the chat that talked a little bit about the CHW policies happening across the country and how they are different and how payment is coming into play. And so I'll start to answer, but I would love for Heidi if you can jump in. I can talk about Illinois. Illinois is working to have a payment for CHW services in place with a state plan amendment. And so they've been working on that for some time. It was done through state legislation, and the certification process has been designed and completed. And we anticipate soon that there will be payment for CHW services in Illinois. And in Illinois, there's been a strong desire for both community health workers who are within healthcare settings and for those who are functioning and working in community-based organization setting. But that is where we are on a path here. We know that oftentimes in many states, and it will likely be the case in Illinois, that CHW payment, may be insufficient and may have a need for high volumes of services. But those are the kind of pieces that will be continued to navigate upon implementation of the state plan amendment. But we're optimistic and hopeful that it will be really helpful for us to continue to build our CHW workforce and really build it into the DNA and infrastructure of our healthcare organizations to help address health-related social needs. So I will pass it to Heidi maybe to give a quick snapshot of the national picture.
Yeah, so nationally, about 30 states do have some level of CHW benefit in their Medicaid state plan. And there's also CHW inclusion now in the Medicare program. So there is a national CHW benefit via Medicare. And in many states are recognizing CHWs, but our comment or the question says it's confusing. It is often confusing because every state has its own state plan for Medicaid, and it is often quite specific to the state as far as who can be a CHW, what a CHW is meant to do, what the service actually is included of, and also what certification is necessary to do that work. So we really rely on kind of an understanding of each state's Medicaid program and being able to navigate the CHW model within each state uniquely.
Great. And I saw Gerald asking a question about health literacy. And so that is a really great question. And I would open it up to anybody on the panel. I will say that there is a physician who worked on really the health literacy question at Cook County Health. And so, I know it's been a priority to really help strengthen the tools that we're using to be able to help, communicate more effectively with the people we serve. And so I don't know if anybody wants to talk a little bit about that health literacy piece and the importance of it.
I can definitely get into that because, again, in the learning collaboratives and other spaces that I occupy, we talk about that very often. And in knowing that the need to constantly learn and grow and share is, again, a necessity. So with health literacy, it is how our communities remain or stay or become healthy because they have this community health worker who is sharing information in a way that they get it, that they understand it, and they are able to actually take that information and apply it. Because much of the pushback in healthcare with our community members is understanding the why. Why is it happening? Why am I taking it? And man, I'm going to be a robot if I get this shot. So we have to address all of these things to a point where they get it, they understand it, and they are able to apply it, and in turn have a better health outcome. So the knowledge happens collectively. It's not an independent thing. It happens collectively. We're all like one band, one sound, sharing the same perspective. So when the information is shared broadly, we are bringing the equity because of the audience that we are serving. We're bringing what they need to share it. In a way that they understand it. If it's language, we want to give it in the right language. If it's about community, we want to have the right community representation um, to share it as well. So the health literacy component is major. It should be one that is often uh, looked into, revised, revisited, so that the information shared is accurate, but it is also community appropriate.
Thank you.
Yeah, and just to add to what Kim J is saying, I think not just thinking about it on the CHW, but how an organization creates organizational health literacy. So, how is it using plain language, in its materials? If it's related to navigation, how are we making that easy for clients, patients, community, whether it's on our website, whether it's, in a particular physical building? How are we engaging community input to make sure that we are communicating in ways? And then ensuring, again, I think to the piece of creating these systems for CHWs is also providing them the training and the capacity and skills building necessary to, again, support their work.
Yeah, thank
And
you.
Letitia, if I may, I just wanted to also state, along with what Gina has stated as well as Kim, is that centering the CHW voices, right? Very important, because they not only are learning, but they have a lot to actually provide as well. And so valuing their lived experience, including them in all stages of planning and decision making, is very vital, right, to the process, to actually implementing, flyers or whatever the case may be, right? It's just really important. And the other thing I wanted to actually discuss briefly is, we do talk about the standardization of CHWs rolling out pretty soon, hopefully in mid or late rather of this year. And so ILTWA, our stance is actually providing that as an option, because we do have some CHWs that really want to be certified and some CHWs that really just want to actually stay for right now, just where they're at. And so, and we want to be clear about standardizing this, right? This model, because while many want clear, standards for the profession, there is also a desire to preserve the wholeness that allows, the CHWs to do the skills that they, the uniqueness of the work that they do within community, right? So we really have to be very flexible in how we actually leverage the standards. And that's something that ILTWA has been working alongside with the Illinois Department of Public Health, comprised of other people in the room. But yeah, that is something that I just wanted to state, because we've heard CHWs state that they're really concerned about it, right? Can they be called CHWs even though they're not actually certified? And of course they're going to be CHWs regardless, right? We have people that have been working in this work 30, 40, 50 years, and have a lot of experience and have a lot of certifications that they've actually gathered over the years. And that needs to be valid, throughout the process.
Absolutely. Yeah, thank you. And I think there was a question that I saw in there about the CHW. So essentially, the CHW state plan amendment, and for Medicaid payment, and Medicare payment, there is a clinical referral that's required for the CHW service. And then there's a certain amount of money that you get for a certain visit. And then, of course, documentation is required. And of course, those folks have to be Medicaid eligible and or Medicaid um, uh, on in the Medicaid program. So those are, the limitations of the Medicaid program, but we also know that community health workers will be continuing to serve, all populations in many community-based settings. So I want to pass it to Heidi. If you want to, I know we wanted to lift one of our other colleagues in one of the examples of some of the work. So I'll pass it over to you, Heidi, as we're closing in the next 5 minutes.
One of the questions in the chat is that someone asks, is there a specific state model that can be used to support CHWs? And Illinois is lifting the social care network model, but it piloted it with community care hubs, health transformation collaboratives. And just want to ask Tiffany if you can allow Kim McCullough Starks just typed in about the Wellness West hub, and just wanted to invite Kim to speak to. Thank you for joining us, and just invite Kim to chime in about what that community care hub methodology would look like that Illinois is supporting and has supported.
So thank you so much, Heidi. Good afternoon, everyone. My name is Kimberly McCullough Starks, and I am the CEO for Wellness West. We are a healthcare transformation collaborative located on the west side of Chicago. I'm really focused on improving outcomes around several chronic conditions such as high blood pressure or diabetes management, and then focusing also on behavioral health, including SMI and SUD. Our model was built intentionally to be integrated across 48 different organizations, including 20 community-based organizations, with the intention of infusing community health workers in the healthcare ecosystem. I can tell you that, our experience has been, elevating the voice of the community health worker as a part of our network so that we have an opportunity to hear from them as trusted members of the community where they, quite frankly, had been experiencing some of the same health-related social needs as the customers that we serve. We found that infusion really helped to inform our workflows. It helped to inform how we, moved forward in addressing and meeting the needs of our customers. I really am interested in learning more about how we can collectively come together to show the value of this infusement of this type of workforce in healthcare in a way that payers recognize that it does, at the end of the day, have an impact on, the total cost of care. It has an impact on outcomes and really, infuses trust in healthcare in a way that I think is probably the most significant opportunity that we've had, in healthcare in decades.
Thank you so much, Kim. That we really appreciate that perspective. And for folks interested in learning more about Wellness West, just put it in the Google machine, and you'll get the Wellness West website and get a chance to see all of the great work that they've done, aligning and really just highlighting the fact that they are utilizing. They have a significant number of community-based community health workers that they've been working with and engaging over the last several years in this model, and has shown tremendous results in the outcomes for the people they're serving and the communities they're serving. So thank you for highlighting that.
Absolutely. I just wanted to add that Wellness West, we are their learning collaborative facilitators. So having that connection to the ecosystem is some of that goodness that works. So just wanted to highlight and lift that up.
Wonderful. Heidi, I'll give it to you to wrap up in the last 2 minutes here.
We so appreciate this opportunity to really lift the voices of community health workers this afternoon during Community Health Worker Awareness Week, and we really invite everybody out there to please not only read the report about the community health worker information ecosystem, because there's some really great material in it, strategies, ideas, stories, and quotes from CHWs about their experience, but also to help us disseminate it. We really want to get the word out. I think a number of our questioners presenters and our panelists really spoke about the importance of talking about the role that CHWs play as trusted communicators in community. And we really do need to resource that. So just really want to thank all of our participants, those who wrote in, and just open it to the group. We have 1 minute remaining. If there's any last quick message that you each want to share, Kim J, I'll start with you.
What I'll just say to anyone is to listen and then activate. Much of what we're trying to do has already been documented. We just have to activate it.
Wandy.
Yes, CHWs are actually, they are a movement, not a moment.
Ah, beautiful.
So let's
Beautiful. Gina.
really highlight that. Thank you.
Yeah, wow, that's powerful. Just from the philanthropic sector perspective, just encourage you to explore authentic relationships and partnerships with philanthropy. I think this assessment is a great example of foundations working in partnership with ILCHWA, with SUI, and others that are so valuable in the CHW space. So I wish I had a slogan or phrase, but I just wanted to lift that up.
Wonderful. Thank you all so much for joining us today. We really appreciate your participation. Have a great rest of your day.
Bye-bye.
Bye-bye.
Thank you.